Today I am going to discuss about subacromial bursitis. You know that subacromial bursa is situated beneath the acromion process and get inflamed during affiliation of neighboring structure of the shoulder joint. The subacromial bursa has a subscapular and axillary nerve ending with the nociceptors such as free nerve ending give information about painful stimulus and inflammatory response to the brain. And also mechanoreceptor in the bursa of the shoulder are capable for giving the proprioceptive information of the shoulder joint position. So the bursa pain can be perceived. Let's talk about the classification. The bursal irritation can be roughly divided into three groups. Number one is a chronic bursitis. The most common and develops our time due to repetitive irritation of the bursa. And at risk people include those who have gout, pseudogout, and diabetes, rheumatoid arthritis, uremia, and other condition can develop a chronic bursitis. Next one is a inflamed bursitis. In this type, the bursa become inflamed with the bacteria. If the infection spread, it causes a serious problem. Next one is a traumatic bursitis. Traumatic or acute traumatic bursitis. It is due to a accident. The bursa could become irritated and inflamed. Next one is a clinical feature. Clinical feature: the patient experience pain during abduction and internal rotation of the shoulder. What is the differential diagnosis? Bursitis frequently caused by another medical conditions. For example, patients who suffer from the subacromial bursitis are likely to suffer from the subacromial impingement, adhesive capsulitis, rotator cuff tendinopathy, supraspinatus tendinopathy, or biseptal tendinopathy. So, what is the diagnostic procedure? We know that bursitis is typically identified by localized pain and swelling or tenderness and pain with movement of the tissue in the affected area. We can diagnose it from the X-ray testing. It can be detect some calcification in the bursa when bursitis has been chronic or recurrent, or the MRI scanning, magnetic resonance imaging can also define bursitis. So next one is physical examination. While to perform a physical examination, we can often diagnose bursitis by a visual inspection. It is possible and noted some redness or warmth, local tenderness or stiffness in the joint with some swelling when the inflammation is worse. Physical examination of the subacromial bursitis revealed a produce active range of motion with decreased elevation, internal rotation, and abduction, primarily because of pain. So the most painful arc of the movement is between 70 to 120 degree of abduction. So the patient feel pain in between painful arc of abduction is 70 to 120 degree. Initially they 0 to 70 they have no pain, but 70 to 120 they have pain in abduction. Some outcome measures are used used for the bursitis, for subacromial bursitis. These are visual analog scale, DASH questionnaire, shoulder pain and disability index, a constant Morley score, and the shoulder disability questionnaire. The basic treatment, we know that some conservative treatment include analgesic, steroid injection, TENS, ultrasound, SWD, immobilization. Immobilization in sling can also help. Gradual mobilization of shoulder can be done by relaxed passive movement, and the resistive exercises can be used for the treatment. And the surgical excision of the bursa is carried over in the incredible case. So these are some basic treatment. When we perform some specific treatment for the different type of bursa, if any patient have a chronic bursitis, is treated by a reduction in the activity that cause swelling. In the chronic bursitis, use anti-inflammatory medicine for a few weeks, as well as icing. We can use icing twice or 3 times per day for 20 to 30 minutes each time until swelling is gone. Heat should not be used since it will increase the inflammation. Injection of steroid into bursa may decrease the swelling, inflammation, but cannot be associated with unwanted side effects, infection, skin atrophy, and chronic pain. These are its side effect of the steroid injection. The injection of the cortisone is the best reserve for those bursa which that did not get better within treatment above. In addition, any bursa that might be inflamed should not be injected with the cortisone. So before the infection, we can use cortisone, but after the infection, so we can't use cortisone. Infected bursitis required immediate evaluation by the doctor. Aspiration of the bursa may be an option to reduce the size and for biopsy. Antibiotics are needed to kill the bacteria. True danger with this type of bursitis is the risk that bacteria can spread into the blood. As with other type of other type of bursal inflammation, ice, rest, and anti-inflammatory medicine can improve the swelling and inflammation. Next one is a traumatic bursitis. Traumatic bursitis is normally treated by the aspirating the bursa, like a small needle to draw fluid or blood from the affected bursitis. So icing and NSAID, anti-inflammatory drugs, maybe mostly effective for to use to reduce the swelling. Next one is a specific physiotherapy treatment. The treatment in the acute phase include the rest for all activity. Number one. Number two is a rise rest, icing, compression, elevation regime to reduce swelling and treat pain. Next one is Conman pendular exercises and active assisted range of motion to keep the joint in motion and prevent the stiffness and speedy recovery. Next one is tapping of the shoulder joint for pain relief and the to improve our function. Tapping is important. Kinesiology tapping to for pain for improve function. Some exercises are used in the therapy program to build up progressively. Number one is a table slide flexion. This exercise start ask the patient to start with your hand on the table, facing the table, on a towel. Stretch your arm forward on the table by sliding the towel. Feel a stretch under your arm. Do 20 to 30 repetition, and this exercise is modified for the abduction as well. Next one is a scapular wall slide. Stand in an upright position with your back against the wall. Rise your arm in 90 degree of abduction and flex your elbow to 90 degree position as wall. Your arm have to be pressed against the wall at all the time. Make sure your hand palm are fast facing forward. Note you will abduct your arm as high as you can while extending the elbow at the same time. Do this slowly and go back to the starting position. Do 10 to 12 repetition. Next one is the upper trapezius stretch. Sit on the table or chair. Use the hand of affected side to grab under the table. Stabilize the shoulder downward with the opposite hand and pull the hand to the opposite shoulder. Maintain your gaze forward and feeling stretch in upper trapezius muscle. Hold for 30 seconds and do 1 to 3 repetition twice time a day. Next one is open book stretch. Place a roll up towel on a mat table between the shoulder blade and lie flat on your back. Keep your arm folded together over the top of your body with your hand together. Open your arm up like you are stimulating the opening a book. Feeling a stretch in front of shoulder. Hold for 30 to 60 seconds and do 1 to 3 repetition twice time a day. Next one is rowing. Using a TheraBand, this is good exercise to train the scapular stabilizing muscle. Sit on the chair or stand. Anchor the TheraBand to the door or pole, making sure that anchor point is around the chest level. Pull the TheraBand backward. Most important, pulling the shoulder blade together, and do set of 10 to 20 repetition 3 times a week. Next one is a low row isometrics. Sit on a chair, push a chair seat posteriorly. Repeat 1 to 3 2 times a day. Next is next exercise which are not mentioned in this PDF. This is a wall push. Ask the patient to stand sideways in front of a wall and push the wall from your humerus, from your arm. So repeat this activity 1 to 3 repetition twice a day. That's all.